Now, which lesion is more common, the aortic stenosis or aortic regurgitation? Both? I think aortic regurgitation is slightly more common than aortic stenosis, and the presentation is different age groups. Now, what is aortic stenosis? It is the obstruction of blood flow across the aortic valve during ventricular systole. The outlet obstruction of the left ventricle is multiple types. One is aortic valvular lesion, then you can have subvalvular lesion, and you can have supravalvular lesion. What is the subvalvular lesion? It is the hypertrophic obstructive cardiomyopathy. Usually if there is asymmetrical hypertrophy, it causes obstruction during the systole. And some of the congenital lesions may cause supravalvular outlet obstruction. Now, this is one situation of pressure overload, that is left ventricular outflow tract obstruction. What is the other pressure overload situation against the left ventricle in addition to this aortic or outlet valve disease? What is the most common and the most important pressure overload situation? It is the systemic hypertension. It is far more common than valvular obstructions. Hypertension is the chronic, sustained, ill-treated hypertension produces similar changes in the heart or the left ventricle as is produced by the aortic stenosis. There is hypertrophy and then there is ultimately failure. So this happens in chronic uncontrolled hypertension as well. Now, what are the causes of aortic stenosis? What do you think is the most common reason for aortic stenosis? Yes? Atherosclerosis is disease of blood vessels, not disease of the valves. The plaques, they develop in the arteries, not in the valves. What could be the reason? Do you think it is rheumatic, it is degenerative, it is congenital, or what? Remember, these are three important causes of aortic stenosis: degenerative, rheumatic, and congenital. Out of which one is more common? Congenital, rheumatic, and degenerative. Degenerative is the most common. The old age presenting with degenerative aortic stenosis is more common, and anyway, even the congenital lesions, they present fairly late. They present in 50s and early 60s. They do not present usually in childhood. So the aortic stenosis generally is a disease of older age group, not of a very young age group. In very rare circumstances, the AS is seen in 4th and 5th decade, but it's usually seen after the 5th decade, and the degenerative lesion may be seen in the 7th and 8th decade. So it's generally the age 65. Before 65, it is usually congenital, and after that, it is a rheumatic type of lesion. Then you got obstructive infective vegetations, if there are large vegetations, Paget's disease of bone, SLE. So these are various causes for aortic stenosis. Radiation of the chest sometimes can present with aortic stenosis. Now, what are the symptoms of aortic stenosis? How does the patient present? Just imagine what will happen if the patient has aortic stenosis. Can you tell me? Hypotension, usually not a presentation of aortic stenosis. With severe aortic stenosis, patients, they tend to have blood pressure on the lower side, but it's not the presentation. Presentation is the patients are asymptomatic for a very long period of time until the surface area is reduced merely to just 0.5 centimeter per meter square of the body. The condition is first diagnosed based on detection of a systolic thrill or a murmur during routine examination. So the presentation may be asymptomatic and it is diagnosed during routine examination. The examining doctor finds that there is a murmur which is heard in the precordium. Most of it is heard in the aortic area. Sometimes it can also be heard in the apical area. So if there is an ejection systolic murmur, this may be the first presentation that the patient is asymptomatic and is diagnosed on the basis of physical examination, and when investigated, patient is found to have aortic stenosis. There are three cardinal symptoms of aortic stenosis. All of them are exertion related. So at rest, patients are generally asymptomatic. So there is exertional dyspnea, there is exertional angina, and there is exertional syncope. So these may be the three presentation. Patient starts exercising and collapses. This may be aortic stenosis. In addition, these presentation are seen in other conditions like hypertrophic obstructive cardiomyopathy. The patient collapses during exercise, and you have examples of athletes dying while in their training course when they are exercising, particularly people in squash court. There are examples, those who have collapsed and unfortunately expired. So exertional dyspnea, it occurs because of elevation of the pulmonary capillary pressure due to reduced compliance and dilatation of the LV. What happens when there is aortic stenosis? There is very high pressure in the left ventricle. The left atrium has to push against this high pressure, so it means the left atrial pressure, they also start rising. When the left atrial pressure, they start rising, this pressure is transmitted to the pulmonary circuit, and pulmonary hypertension starts developing. And when the patient exercises, this compromises the pulmonary functions and results in patient developing exertional dyspnea. And then patients have exertional angina. So I told you yesterday, the patients with aortic stenosis may present with angina even with normal coronary arteries. So this is one condition when there is no atherosclerosis, but the patient may develop angina because of very high oxygen requirements of this thickened muscle, which is not met by the routine coronary circulation. So if the patient starts exercising, the metabolic demand of this thick myocardium is not met by the routine blood supply. So that may develop, the patient may develop exertional angina. And then exertional syncope, when patient starts exercising, there may be arrhythmias, particularly ventricular arrhythmias. There may be ventricular tachycardia, or even there's some bradycardias. So patient develops hypotension, there is decreased cerebral perfusion resulting in increased blood flow to the exercising muscles. So when the patient starts exercising, the blood starts going into the exercising muscles, and there is inability to increase the cardiac output because there is fixed obstruction at the left ventricular outlet. So the cardiac output cannot be increased. That results in diminished flow of blood to the central nervous system, and the patient may have syncopal attacks. Now, what are the clinical findings in aortic stenosis? Now, how do we diagnose aortic stenosis? What's the diagnostic sign, which is hard diagnostic sign of aortic stenosis? Hard sign is that this is very specific for that particular condition. So it's not seen in other conditions. So what is the hard physical sign which you can surely say that this patient has aortic stenosis? Come on. It is the anacrotic pulse. Anacrotic pulse seen at the neck is the diagnostic of aortic stenosis. The character of anacrotic pulse is not seen at the wrist. It's examined at the neck, and if this is a slow rising pulse or anacrotic pulse, this is aortic stenosis. Neither the murmur nor the character of the apex is diagnostic of aortic stenosis, because the apex can be, similar apex can be seen in systemic hypertension, and an ejection murmur is fairly common. It may be just functional murmur because of sclerotic valves without stenosis, so there may be a murmur. So the murmur and the character of the precordium generally is not diagnostic, but if you can pick up that characteristic pulse of aortic stenosis, it is diagnostic of aortic stenosis. In the precordium, you see systolic ejection murmur at the aortic area. This may be transmitted to the neck, and sometimes it may be heard in the apex as well. Palpable left sternal thrill or a heave. There is a weak or absent aortic second sound, reverse splitting of the second heart sound. Now, why there is reverse splitting? What are other conditions when you see? What does it mean by reverse splitting? What happens in first heart sound? The aortic sound comes first and then comes the pulmonary sound. Is it like this? So what is reverse splitting? That the pulmonary sound comes first and the aortic sound come afterwards? No. It's actually, we see physiological splitting is seen in inspiration. The split widens in inspiration. Now when we call it reversal of the split, it widens in expiration. So it's nothing to do with the valve closing one or the closure of the valves is changing. It's actually the separation of the sounds of the semilunar valves. It occurs in expiration when the splitting is reversed. Normally it's increased in inspiration, and right-sided lesions, it increases in inspiration, while in this condition and left bundle branch block, it causes reversal of the split. It widens in expiration. What is the condition when there is fixed wide splitting of the second heart sound? Have you gone through the congenital heart disease? It is atrial septal defect. When you have a fixed wide splitting which does not vary with respiration, it's the same in inspiration and expiration. S4 is common because the ventricle is stiff, and when the atrium pushes against this stiff ventricle, fourth heart sound is generated. So these patients may have fourth heart sound. So there may be changes in the split, fourth heart sound may be present, and there is an ejection murmur. Now, how we diagnose aortic stenosis? ECG will show some changes: chest radiography, echocardiography, Dobutamine echocardiography, cardiac catheterization. Now, what is seen on ECG is left ventricular hypertrophy. This is the classical feature of aortic stenosis on ECG. How do we see left ventricular hypertrophy? We've forgotten that? Duration is not important, it is the amplitude or the voltage which is important. Combined V1 and V6, if it is 35 or more, this is voltage criteria for hypertrophy. There may be other changes like left atrial enlargement. As I mentioned, there is increase in the pressure in the left atrium. There may be left axis deviation. There may be left bundle branch blocks. So you may see all these on ECG. It's not a reliable test because there are wide variation in aortic stenosis which are seen in other conditions as well. So ECG may be suggestive that this patient may have LVH and this could be aortic stenosis, because similar abnormal findings may be seen in hypertension or hypertrophic cardiomyopathies. So it may not be a reliable feature. This is what we see ECG. The V1 and V5 combined, they are more than 35 millimeters, that's 40 millimeters. So this is LVH. Chest X-ray may show a normal sized heart because the hypertrophy is at the expense of the lumen. The lumen becomes narrow when there is hypertrophy. The heart size actually does not increase. So the chest X-ray may show a normal cardiac silhouette, or sometimes if this has started failing, then it may dilate, but this is unusual for aortic stenosis. When aortic regurgitation, you find a bigger heart. There is calcification of the aortic valve which may be visible, and there may be dilatation and calcification of the ascending aorta. So this is what we may see on chest X-ray. Again, these are very non-specific findings which do not tell you about the presence of an underlying aortic stenosis with certainty. So this is just a supportive investigation. Now this is the best investigation we have. Now you see the RV cavity and the LV cavity. In the bottom left side is the RV cavity, and on the top right side you see the LV cavity. The LV cavity has become small and you see the thickness of the muscle mass. So the muscle has become very thick. So it is useful in assessing the severity of aortic stenosis, the degree of coexisting aortic regurgitation, LV size and LV function. What sort of dysfunction do you see in aortic stenosis? What is the characteristic dysfunction in the muscle when we see on echo in patient with aortic stenosis? It is systolic dysfunction or diastolic dysfunction. So whenever the muscle becomes thick, it's a diastolic dysfunction. Have you gone to gym anytime? Any of you have been doing a lot of strenuous weight training? None of you? You mean, so what do you find that after the training, the muscles are very stiff. It's difficult to move them. So this is what happens when they are hypertrophied, the tone is high and it's difficult to relax, and you can assume that posture. So this is what happens when the hypertrophied muscle is, there is diastolic dysfunction, there is failure of relaxation. Keep in mind, in heart, the contraction and relaxation both are active phenomena, not like lungs. When the inspiration is active, the expiration is passive because of the elastic recoil. The lung expands, the elastic tissue causes to fall at back when inspiration stops. Normally, no expiratory muscles are working. They only work when there is forceful breathing. While in heart, it's different. Both systole and diastole are active energy-dependent process. So there is difficulty in relaxing the heart. So patients have diastolic dysfunction. It's helpful in estimating pulmonary systolic pressure and identifying other cardiac abnormalities if they are present with AS. Transesophageal echocardiography may be useful because it gives a very good picture of the aortic valve orifice or aortic valve itself, because the esophagus lies very close to the aortic valve and we put the scope inside it. It's a very good visual description of the aortic valve which can be seen on transesophageal echo. Now, dobutamine echocardiography, we give the patient infusion of dobutamine. What dobutamine causes is increase in the myocardial wall stiffness. It increases the stiffness, force of contraction. It is indicated in patient with moderate aortic stenosis, and it should not be done if you're suspecting the patient has very severe aortic stenosis, the valve area is low, the pressure inside the left ventricle are high. Don't try to use this test. This is done in moderate aortic stenosis with LV dysfunction to predict the reversibility of LV dysfunction after AVR, that is aortic valve replacement. Keep in mind, the treatment of aortic stenosis is aortic valve replacement, no medical treatment. So you have to assess what will happen if we replace the valve. Is the left ventricular function going to improve, or if it's not going to improve? If you see the patient's LV function does not improve after surgery, then what is the fun of doing such a surgery? So we need an assessment before that. Is it going to be useful that we go for surgery? Patients with aortic stenosis, LV dysfunction and relatively low gradients have better outcome when management decisions are based on results of Dobutamine echocardiogram. So this is an important test pre-surgery. Cardiac catheterization. Do we require catheterization in patients who've got aortic stenosis? The echo can tell us this is an obstruction, this much is the obstruction, this is the pressure. Do we need echocardiography? When do we need this catheter studies? When there is discrepancy between the clinical picture and echocardiographic findings. The echocardiographic findings are going in one way, the clinical findings are going on the other way, then you need catheter studies, because in this situation there is a possibility that the patient may be having another lesion which is not identifiable on echocardiography. So whenever there is discrepancy between the clinical features and the echocardiographic findings, we go for catheter studies. Indicated for young asymptomatic patients with non-calcific congenital AS to define the severity of obstruction to LV outflow, and it is important to see if we suspect the LV outflow may not be the aortic valve but rather in the sub or supravalvular regions. So if we're suspecting the echo is not clear, the aortic valve is working well and we still have the features of obstruction. So that's what I said. When there is a discrepancy in clinical and echocardiographic findings, we go for this. And if we are planning surgery and we are suspecting the patient might have underlying coronary artery disease, we go for catheter studies to see at the same time what is the situation of the coronary arteries, because the presentation of aortic stenosis is usually in older age group, and that's the age group when there is a possibility of developing atherosclerotic aortic cardiovascular disease as well. So in patients when we are suspecting that they may have accompanying coronary artery disease, we go for catheter studies as well. Now how we grade aortic stenosis? It's graded on area. It's mild aortic stenosis, area is greater than 1.5 centimeter squares. In moderate, it's 1.1 to 1.5 centimeter squares, and severe, it's between 0.75 to 1 centimeter squares. So this is how we grade that this is the severity of the aortic stenosis. Pharmacological management, as I mentioned, no pharmacological treatment is available for aortic stenosis which can change the course of the disease. If the patient has LV systolic dysfunction, inotropic agents may be used. What are the inotropic agents? Yes? Come on. Which increase the force of contraction, inotropic drugs. What are the chronotropic drugs? Which increase the rate of contractions, increase the heart rate. So we can use some inotropic support if the patient has LV systolic dysfunction. Now what are the inotropic drugs which are available which can be used? Problem is most of them are intravenous. Dopamine, dobutamine, isoprenaline, they are all in fact, isoprenaline is not used for this purpose. It's the dopamine and dobutamine, but they are injectable drugs. So only inotropic drug which we are left with is digoxin. So for oral use, we have digoxins available. Now, surgical management is aortic valve replacement is indicated for any patient who is symptomatic. AVR improves survival in patients with decreased as well as normal LV function. The risk of surgery and prosthetic valve complication outweigh the benefit of preventing sudden cardiac death, prolonged survival in asymptomatic patients. So if the patients are asymptomatic, do not go for the treatment because the risks of surgery and subsequent complications are more if the patient is asymptomatic. So go for replacement in patients who are symptomatic. So we do not treat patients who are asymptomatic. Now these are different type of valves available. Bioprosthetic valve, it may be porcine, it may be mechanical valve, it's called St. Jude valve, and you may have homograft. What is a homograft? You take the aorta and the aortic valve from a cadaver and place it in the place of abnormal valve. So you can have a homograft. So these are different type of grafts which are available. So you see on the lower picture, these are the metallic St. Jude type of grafts. These are two discs, they can close. So the other one is the bioprosthetic porcine graft. So this is aortic stenosis.